Hi there, it's Dr. Amy Zwecka, and this is my second lecture in my series on eye movements. And this lecture is cortical and brainstem gaze control. And our objectives are to identify the regions of the cortex and brainstem involved in the movement of the eyes, to distinguish between saccadic and smooth pursuit eye movements, noting the cortical areas responsible, identify the location of the horizontal conjugate gaze center and the center for vertical gaze, and describe the pathway for horizontal conjugate gaze, noting each component and its location, and to describe the effects of lesions to the horizontal and vertical gaze pathways. So here's our diagram of the visual gaze control, and very complicated with inputs from cerebellum, from brainstem, from the vestibular nuclei, and with the final output being the extraocular muscles. So today we're going to talk mostly about the gaze centers as well as the cerebral control of vision. So to do this, the best way to kind of start with this is to talk about the classes of eye movements. So the first class of eye movements to describe are saccades. Saccades are quick volitional movements that refocus the eye so that the subject is on the fovea. You have 120 degrees of vision in both of your eyes, but the central 20 degrees are the most sensitive and what you use for the majority of your visual processing. So in order to make sure that the macula, or the central vision, is always on the subject that you wish to analyze, saccade movements were kind of a necessity to best use the macula. So these quick volitional movements are best described or kind of visualized by seeing this, looking over to the right. And so what this is illustrating is how eyes move around the face to process the information so that it could put the whole image together. As you can see, there are a lot of movements back and forth between the eyes and to different areas of the face to look for distinguishing features that help to figure out, help your brain figure out what it's looking at. These saccades originate in the frontal eye fields, or area 8. And these fields will direct saccades to the contralateral side for visual processing. So the left frontal lobe is responsible for directing saccades over to the right and to pick up information in the right side of the vision. If there's a lesion of the left frontal eye field, then there is an inability to generate saccades to the right, and it causes a left gaze preference. This is a video showing slowed saccades. To look at normal saccades, just ask to look at your neighbor's finger, or have them look at your finger and then look at your nose. That's what this subject is currently doing, is having his eyes go back and forth between two subjects. And as you can see, that movement is very slow. It is typically a very fast movement. And so this is someone who has problems with both frontal lobes, because both saccades to the right and the left are very slow. Smooth pursuit is a voluntary movement. And we don't naturally create any sort of smooth pursuit. We naturally do it because we are tracking an object. It's trying to keep the retina on whatever image you are trying to follow, and the idea is that it keeps the eyes on whatever you're looking at and prevents that slippage back or forth. This is coordinated by the occipital cortex in the secondary areas 18 and 19. And so here's an example of someone who has saccadic smooth pursuit. You can see that the eyes kind of jump around. They don't stay nice and smooth. There's little stops in there. Let me start that over from the beginning. Again, looking at her smooth pursuit here. Notice how it's not smooth. There's actually little stops in the action, particularly when the eyes are moving over to the right. The left is fairly smooth, but to the right they are a lot more abnormal. So like we said, there are two major areas for the control of these eye movements. We have the frontal eye fields that are responsible for saccades, and the occipital lobes that are responsible for smooth pursuit. The way that you can remember this is saccades are voluntary, and the frontal eye fields are in the frontal lobes, which are responsible for much more responsible for voluntary anything. Whereas the area for smooth pursuit is in the occipital lobe. And this is involuntary, and it's actually kind of mediated by the striate cortex. Like it's actually an involuntary action where the occipital lobes are just trying to keep an object in the central gaze. The frontal eye fields are constantly sending signals to the brainstem. If you have a lesion of one side, it causes unopposed signals, and so there will be a gaze deviation towards the side of the lesion. So, for example, if there is a lesion of the right frontal lobe, the left frontal eye field will take over and drive the eyes over towards the right side. So the patient looks towards the side of the lesion. If there is stimulation of an area within the frontal eye field, such as with a seizure, then that side becomes hyperactive and overcomes the normal side, and the patient will then deviate towards the normal side. So if you have a seizure originating from the right frontal lobe, it will drive vision over to the left side. There are other classes of eye movements, in particular some that we will talk in a little bit, including optokinetic nystagmus and vestibular eye movements. And then, of course, there's vergence. So these are when eye movements move towards each other in order to keep an object in the same area of the macula despite being closer or further away. And so it's more associated with convergence and divergence. In the cerebellum, there is a horizontal and a vertical gaze center. In general, the horizontal eye centers are located in the pons and are centered around the sixth nerve nucleus. In the sixth nerve nucleus, there is the MLF that connects the sixth nerve nucleus up towards the third nerve nucleus, which is right here. There's also the fourth nerve that is located in kind of the pontine midbrain junction. And we have the vertical gaze centers that are located in the midbrain above the third nerve nucleus, but include the rostral interstitial nucleus of the medial longitudinal fasciculus, or the RIMLF, and the interstitial nucleus of Cajal, or the INC. The horizontal eye movements are controlled primarily by the cortex, which sends information to the PPRF. From the PPRF, signal is sent to the sixth nerve nucleus. The sixth nerve nucleus sends out two signals in response to a call for a gaze deviation. There is one signal that goes via the sixth nerve to the lateral rectus to send the eyes over to the right. Also, there has to be a signal that goes over to the medial rectus. In order to get to the medial rectus, it has to get to the third nerve nucleus, and in order to get there, it has to travel via what's called the medial longitudinal fasciculus. So when the signal comes down to the PPRF, and the PPRF sends that information to the sixth nucleus, there is the signal that goes to the lateral rectus via the sixth nerve, and there is a signal that goes across the midline and ascends via the medial longitudinal fasciculus to the third nerve nucleus, and in particular to the nucleus of the medial rectus. That then sends information to the medial rectus, and then both eyes will look over towards the right. If there is a lesion of the medial longitudinal fasciculus, there will be an adduction deficit on the side of the lesion. So what will happen is the frontal eye fields send their information to the PPRF. The information easily goes to the lateral rectus because the sixth nerve nucleus is intact. And so if the patient is trying to look over to their left, the eye that abducts will be fine. However, the information that has to go to the contralateral side, to the medial rectus, has to cross midline and ascend via the MLF. If there is a lesion in the MLF, then the third nucleus never receives the information to adduct, and there is no adduction. Often what will happen is that there will be abducting nystagmus in the normal eye because of attempts within the brainstem to overcome the deficit. Depending on where the lesion is, occasionally this adduction will actually be overcome by convergence, so trying to look at a near object, the eyes will adduct just fine. And because some of the vertical eye movements travel within the MLF, there occasionally will be associated skew deviation, which means that there's an elevation of one eye over the other one. That is due to a central cause. So this is a video of internuclear ophthalmoplegia, and that is the lesion that occurs in the setting of a lesion of the medial longitudinal fasciculus. So we'll go ahead and play this video, and this is a video of saccade back and forth between two objects, and you'll notice when the patient looks over to the left that the abduction is full, but the adduction of the right eye is incomplete. They do not completely bury the right eye when the patient is looking to the left, but you'll also see that there's this nystagmus movement of the left eye. I'm going to play that one more time. So the left eye kind of shakes a little bit. It's almost like it's trying to pull the right eye over, if you'll appreciate that. And so this is a classic lesion of the brainstem affecting the medial longitudinal fasciculus on the right side. The side of the adducting deficit is the side of the lesion. So this is a diagram of the vertical gaze centers. And this is a much trickier pathway, and one that I wouldn't recommend spending a great deal of time struggling over. This just basically illustrates the complicating components because there are multiple nuclei involved in elevation and depression of the eye. And then making things even more complicated is the introduction of the vestibular nucleus, which contributes a significant component to eye movements, as it helps with the head rolling and both horizontal and diagonal head movements are primarily controlled by the vertical gaze centers as well. So the main thing to draw out of this is that both the rostral interstitial nucleus of the medial longitudinal fasciculus and the interstitial nucleus of Cajal are both instrumental in this pathway. The prominent deficit that is most associated with a deficit of the vertical gaze is what's called a supranuclear gaze palsy. And this typically is a lesion that occurs in the setting of neurodegenerative disease, in particular progressive supranuclear palsy. I'll go ahead and play this video, but what you'll notice is that this patient cannot volitionally elevate his eyes. So what this is kind of indicating is that when he is told to look up, you can see his eyebrows furrowing as he's trying to raise his eyebrows or raise his eyes, but the eyes do not go up. What this is what is happening is that the signal coming from the cortex is actually being blocked in the midbrain. So the tricky thing, and what isn't shown in this video, is that if you were to passively move the eyes up and down by having the patient look at an object and move the head up and down, what's called a doll's eye maneuver, or the vestibular ocular reflex, the eye movements potentially would be full, because the brainstem mechanism isn't entirely intact. The VOR, the vestibular ocular reflexes, are specific to the brainstem and require no cortical control. But what is being illustrated here is if the cortical control is cut off, the patient cannot volitionally look up. And so that's what's happening in supranuclear gaze palsy, is that even though the machinery are there, the patient cannot access the machinery to perform a specific task. So supranuclear gaze palsy is initially a decreased ability to look up, usually with slow vertical saccades. Eventually it can involve horizontal eye movements. Sometimes these patients will have lid retraction and a decreased blink rate, and you can overcome this with the oculocephalic, otherwise known as the vestibular ocular reflex. This is classically seen, as I said, in a neurodegenerative disease with midbrain pathology, particularly progressive supranuclear palsy. Another classic syndrome caused by a defect of the vertical gaze centers is the dorsal midbrain syndrome. And this occurs when there is a lesion that affects the dorsal area of the midbrain. So this is the dorsum, this is the ventral component. And the important structures to note here are the cranial nerve 3 nucleus, the Edinger-Westphal nuclei, which are for pupil involvement, and the superior colliculi here on the edges. The dorsal midbrain syndrome causes a supranuclear vertical gaze paresis from its effect on pathways going from the cranial 3 nucleus to the vertical gaze centers. They often have a convergence retraction nystagmus. They have lid retraction and pupillary light near dissociation due to effect of the crossing fibers over the cerebral aqueduct coming from the Edinger-Westphal nucleus. So this is an important lesion to think of as well, and this is typically caused, if you look at the sagittal view here, the dorsal midbrain is right here, and so this is actually very close to the pineal gland. So in cases of pineal gland enlargement, sometimes it can compress the dorsal midbrain. Also, causes of hydrocephalus can cause the dorsal midbrain syndrome. Also, if there is a structural lesion within the midbrain, such as a stroke or a tumor, you can develop a dorsal midbrain syndrome. So here's a video of convergence retraction nystagmus, which I mentioned is a manifestation of the dorsal midbrain syndrome. And it's so unique of an eye movement because it really demonstrates the inability for the eyes for the brain to communicate appropriately with the brainstem. And so what this video shows is they're using an optokinetic nystagmus drum that creates the sensation of trying to drive the eyes up through reflexive mechanisms. And so what you'll see is when the patient is looking straight ahead and looking at the OKN drum, is the eyes are actually coming in together towards each other. And so that's the convergence component. But then when you look from the side, the eyes are actually being pulled back into the socket a little bit. And that's because the information is unable to be appropriately used. The eyes are trying to reflexively be driven up by the cortex, but the information is going to all the vertical gaze movements and eye movements, and basically making all the eye muscles contract, and that pulls the eye backwards. I'll just show that one more time. So there's the convergence component on attempted up gaze, and then there's the retraction component that occurs with attempted upward gaze. So convergence retraction nystagmus is a fairly unique finding, and I just wanted to kind of demonstrate to you one of the more unique things that we see in neuro-ophthalmology. I hope that you find all of this very interesting. In summary, we talked about the horizontal gaze centers, primarily in the pons, and the interaction between the PPRF, the sixth nerve nucleus, and the medial longitudinal fasciculus. We also talked about the vertical gaze centers, which are located in the midbrain and the upper pons, and include that rostral interstitial nucleus of the medial longitudinal fasciculus and the interstitial nucleus of Cajal, and the interactions between those and the third nerve nucleus. Finally, we talked about disconnection syndromes that occur between the cortex and the midbrain and cause things like supranuclear gaze palsy and a dorsal midbrain syndrome. So I hope you enjoyed learning about these, and please feel free to reach out if you have any questions going forward, and I look forward to seeing you at the iFair and in our teaching sessions.